Good afternoon, everybody. Post-lunch session. So I'll be talking about progressive myopia, which is a little offbeat of the what the instruction course is about. So as we all know, myopia has been increasing prevalence in the last 2 years, especially post-COVID. We have all seen in our clinical practice. And it is estimated that in 2020, there were only 2,620 million cases of myopia, which is going to increase to 3,361 million by 2030. But more importantly, the high myopia, which leads to pathological myopia and macular degeneration, this is supposed to become the most important cause for irreversible blindness worldwide. So that is the reason why we are so much worried about this progressive myopia. Previously, we used to think myopia is only genetic and we used to ignore all the other factors, but now we have enough evidence to say that besides the genetic factors, environmental influences have a very great role in onset and progression of myopia. So now we know that it's a complex interplay between the environmental and the genetic factors, wherein the control mechanisms are no longer able to coordinate with the growth and development of the optical components of the eye. And there is also this peripheral defocus theory. So what exactly is this peripheral defocus? Like suppose in uncorrected myopia, when the light falls through the center of the receiving eye, it falls in front of the fovea, as we all know. Whereas in the peripheral area, since the eye is actually not a perfect sphere, it's oval in shape, the peripheral rays are overshooting either on the retina or behind the retina. So this is something called the hyperopic defocus. So when we are giving a normal correction, like in a normal spectacle this thing for myopia, we are going to correct only the central rays. So the central rays focus on the retina, whereas the peripheral rays gets more defocus, means gets more hyperopic. It focuses behind the retina. And this peripheral defocus has been a very important factor in the progression of myopia, because this leads to some cellular and biochemical changes in the retina and the RPE, leading to changes in the scleral extracellular matrix synthesis, which alters the biomechanical properties of the sclera and in turn leads to increased ocular growth and myopic shift. So why at all we are worried about this progressive myopia? Why should we just bother too much about it? Most important, as I said, this degenerative retinal disease, because this has been hypothesized to be the cause for the most important cause for blindness worldwide in the coming years. So currently available modalities for this progressive myopia, the one is the regular spectacle lenses, the contact lenses, but now the importance is on the environmental factors as well as the pharmacological modifications. So environmental effect has been shown clearly to have a very huge impact on the onset progression of myopia, and hence modification of these factors or reduction of the exposure of the eye to these influences may definitely slow down the progression. So it has been recommended that at least 2 hours of outdoor activities for children has been shown to significantly reduce the rate of progression. And the mechanism is that the light stimulated release of dopamine from the retina, and then this dopamine is supposed to inhibit the axial length elongation. So here it is important to remember, it's just not the physical activities, it's just being outside in the exposing to the sunlight, that itself has been shown to reduce the rate of progression. The optical coming to the next factor is the optical factor. Optical undercorrection has been the very age-old method of treating, but however current evidence is against this undercorrection of myopia, and in fact it may lead to more progression than normal. The bifocal and progressive lenses have also been used in effort to reduce the accommodative effort, and this particularly is effective in children who have the accommodative lag. They usually have a esophoria on near fixation. So such children, the progression of myopia can be halted to some extent by using this progressive glasses. Of late, there has been a lot of interest in this DIMS lens, the defocused incorporated multiple segment lens. So this is based on the peripheral defocus theory, which I just discussed. So here you'll have a central area which gives the clear optical correction for the child to see, and the peripheral area is hyperopic, means it has about plus 3.5 hyperopic segment. So thereby the hyperopic defocus, which is supposed to be happening in the peripheral retina, is avoided, and this has been shown to reduce the rate of progression of myopia in many children. and it has been extensively used nowadays. We also have contact lenses in a similar the same platform. So in this is one of the most popular daily disposable lens available. So here again there are treatment zones and the zones for the optical correction, so that the central area, the vision is still clear for the child, but at the same time we are avoiding the peripheral hyperopic defocus, and we are creating into a myopic defocus instead of a hyperopic defocus. So this has been shown to again reduce the rate of progression. Orthokeratology has been a very age-old method when you practiced especially from by optometrists, and of late a lot of ophthalmologists are also using this one. So the basic principle is the child is made to wear a hard contact lens and sleep. So because the eyelid pressure is on the lens is supposed to flatten the cornea, and when the lens is removed in the daytime, the myopia gets corrected. However, I have no much experience about this ortho-K lenses. The pharmacological modification has been the most important innovation in the last few years, and atropine is the only medication which has demonstrated to be consistently effective. I'll just discuss about this ATOM study. So how does atropine work? Atropine works not through the accommodative system, but it affects through the M4 and M1 and M4 receptors, and on the non-muscarinic and a direct influence on the scleral fibroblasts. So this was a very big study done in Singapore National Eye Center, the ATOM1 and ATOM2 study. So the ATOM1 study used 1% atropine, and however this was affected with a lot of problems because of the pupillary dilation, photophobia, and difficulty in near vision. And not only that, the rebound myopia was higher on stopping the treatment. Whereas the ATOM2 study used the 0.5, 0.1 and 0.01 atropine for treatment. And in this study, they found the 0.01 works the best. So the 0.01% works the best. It has a significantly lower progression compared to all the other concentration, and also the children tolerate it very well. So atropine causes very minimal side effects, especially the 0.01%. This thing does not have much of blurring of near vision or photophobia, unlike the higher concentrations. So combination of therapy, combination of intervention is probably the way to go. So we have to see the child, the family history and all the other things, and then decide whether a combination of atropine with the multifocal spectacles or orthokeratology with low dose atropine, whichever works for the child the best. So a word about the pre-myopes. This is very important because we have to focus our attention on these children. So presence of 0.75 diopter or less of hypermetropia at the age of 6 years indicates that this child is more likely to develop myopia. So hence we have to give a lot of importance to these children, and especially if there is a family history of myopia, parents or siblings having myopia. So such children, we should encourage them to spend more outdoor time and try to restrict the myopia. So in conclusion, outdoor time is the most promising intervention method for preventing progression of myopia, and consistent evidence is there for use of 0.01% atropine eye drops. And of course, information is constantly evolving, and we have to stay abreast with the latest studies. Thank you.
Thank you, Dr. Arun. And if anyone has any question about this,